I got into endocrine surgery basically because opportunities were presented to me. I had liked endocrine surgery during my training, but where I was trained, there wasn't a lot of endocrine surgery being done by head and neck surgeons. That was the case in my residency, and even so during my fellowship. And so when an opportunity was presented to me when I was on the faculty at Penn State University, where my predecessor endocrine surgeon was starting to slow down his practice, I was given this opportunity to jump in, and that was back in 1999. And I saw this as a great opportunity to pursue my interest, also to blend nicely with my head and neck surgery practice at the time. And so it worked out well. I was able to get very concentrated in endocrine surgery very quickly and be able to build up a reputation that allowed me to then move to another university, University of Arkansas for Medical Sciences, and continue on with that emphasis. So after medical school, matched in otolaryngology head and neck surgery. And there was a brief period of time in the late 80s and early 90s where otolaryngology programs were 2 years of general surgery and 4 years of otolaryngology. Not all of them, but some of them. And I matched in one of those programs. So I did 2 years of general surgery, which gave me a great basic foundation in all things surgical, critical care, and trauma. And then I proceeded on to otolaryngology, and in my particular program there was a big head and neck cancer emphasis. So I felt really comfortable doing big head and neck operations, although we were doing them for squamous cell carcinomas and salivary gland malignancies, not so much for thyroid problems or parathyroid problems at the time. And then I went on to do a 2-year accredited head and neck oncology and reconstruction fellowship at the University of Washington. And during that fellowship, again, I did not have a lot of endocrine exposure, had some endocrine exposure, but mostly I was able to really reinforce the surgical principles I had learned during residency. And I also did a 1-year molecular biology postdoc at the Fred Hutchinson Cancer Research Center. So I was able to really gain extra experience in research and extra competencies in doing research. Well, I really enjoy the endocrine surgical patient. Unlike head and neck squamous cell carcinoma, traditionally, which was from smoking and drinking, and the prognosis was very poor when someone came in with advanced stage disease. Thyroid cancer, generally speaking, was a little happier cancer to deal with. I know that sounds contradictory, but we had better results, and that was very gratifying, taking care of lots of females that had thyroid issues, more so than males, which is the opposite of what we experience in head and neck squamous cell carcinoma. But something I particularly enjoyed working with was parathyroid problems. And this was something I became exposed to as I got more involved in thyroid surgery. And this is my favorite part of endocrine surgery, is taking care of people that have elevated calcium due to hyperparathyroidism. We know that these people, if left untreated, have a higher risk of heart attack, stroke, bone disease, and kidney disease. And it's a very preventable disease in the sense that or a very treatable disease, I should say, in the sense that with our state-of-the-art imaging and minimally invasive surgery, we were able to treat these patients quite effectively. I find doing revision surgery very challenging. About 50% of surgeons that do endocrine surgery do 5 or fewer cases a year. So there are lots of cases that end up needing to be remediated by a second surgeon. About 1/3 of my practice is doing revision surgery on other surgeons' cases. And I find that to be interesting and stimulating and gratifying, because I'm able to help a person that's in a tough spot at that point in time, and perhaps maybe has lost a little confidence in the practice of medicine in general, maybe in their previous surgeon in particular. And hopefully I'm able to remediate their problem and give them a satisfactory result, and I find that very gratifying. Research has been in my DNA since I was a resident. I wrote a lot of papers in residency and continue to write and do a lot of research. And as I became clinically focused in endocrine surgery, my research followed my clinical passion. And so probably my last 70 or 80 publications now have been just related to endocrine surgery. And areas that I'm interested in are minimal access surgery, the preoperative imaging that we use in order to optimize our surgical results, and an interesting area, a new interest for me that I'm doing a deep dive in, is combining the advantages of big data, aggregation, and the tools that we have to look at big data, and looking at an underlying cause for hyperparathyroidism. Most of us as surgeons have looked at hyperparathyroidism as a surgical disease, which it has historically been, but very few of us have asked us, well, why are these people coming with this disease? We know a very small cadre have a certain genetic mutation, and we identify those and we examine their families and see if they need the surgery, but that's pretty much where our curiosity about hyperparathyroidism has stopped. And so I've been very interested in risk factors that may lead to this disease, as this disease has been on the increase in the Western world over the last few decades, and see if any of those identified risk factors could be things that we could mitigate through changes in behavior, changes in lifestyle. And so I'm very excited. We're at the very beginning of looking at very large databases as it relates to this problem, and it may end up becoming a negative research result, or it may be something that's positive and impactful. I have a large family, and I spend a lot of time doing fatherly responsibilities. I have 7 children, and so right now we're in sort of a transition phase. Half of the children have left the nest and are at college and require just as much tender loving care during that period of their life as they did when they were in the house, and certainly as much financial support. And then we have the children still at home, and we're trying to support them in their activities and their interests, and we're trying to prepare ourselves to be grandparents in the near future. Well, we have a little acreage, and we have in the past had rabbits and sheep and alpacas and goats, basically all animals that produced fiber, because my wife and my 4 daughters are spinners and knitters and weavers. And so we basically had this animal facility to support that interest of theirs. Over the last few years, we're down to dogs, and we're considering horses. Actually, our property is a horse property, and yet we've never had horses on it, so we may ultimately get some horses.